3D, our ultimate authority, our go-to guy for advice on post-vasectomy pain. Ladies and gentlemen, Sijo Parakattle.
And thank you so much for the kind words. Really, really appreciate it. And honored to be with all of you. You guys really are the forefront in terms of doing vasectomies all over the world. And so, really honored that you would allow me to speak to you guys. And again, if you guys ever have any questions and stuff, feel free to reach out to me directly. At the end of the day, we just want to do a good service for our patients, and that's the bottom line. Feel free during the talk to ask any questions and stuff in the chat thing. I'll try to keep an eye on that. And the way we've structured the talk is about 10 to 15 minutes of talk, and then really just question and answers, for another 10 or 15 minutes. So feel free to list your questions in, and we'll try to hit all of them. So I guess we'll start with the presentation. If the technician can put the first slide up. So just give us a moment, and then if you guys need me to share my screen, I can do that too, but let me know. Okay, here we go. Okay. Thank you very much. Okay, so chronic post-vasectomy pain syndrome does exist, an evidence-based management algorithm. So this is something that is difficult to deal with. And, vasectomy is a great option for contraception. And however, like everything in life, whenever we do something, there's always probably some percentage of individuals that may not have the best outcome, after we do something. And so I have an interest in chronic pain in the scrotal area, and very, very intrigued by patients who develop chronic pain after a vasectomy. Next slide, please. So no disclosures. Next slide. So we'll start with just a basic introduction into what is chronic pelvic or post-vasectomy pain syndrome, the pathophysiology or estimated pathophysiology. How do we assess this pain? A treatment algorithm, some conclusions, and then we can kind of open up for a Q&A. Next slide, please. So one of the toughest issues is what exactly is chronic post-vasectomy pain syndrome, or PVPS. It can also be labeled as chronic scrotal content pain. The official definition is probably pain that lasts for more than 3 months, no definable pathology in exam or ultrasound, and refractory to conservative treatment options. There's a recent meta-analysis that I'll go over in detail that just came out last year that really looked at a bunch of studies and has really tried and figure out what the rate of PVPS is. And in this meta-analysis, they came up with a 5% rate. And this is for chronic post-vasectomy pain syndrome, more significant and debilitating pain that patients are usually seeking further treatment for from that standpoint. Next slide. Now, this study was performed by Dr. Ayung and the group at the Royal College of Surgeons in Ireland. Basically, it was a systematic review and meta-analysis over the last 20 years or so. They looked at almost 733 different studies and papers, and they selected out 18 papers on 25. It was basically 25 separate databases, 11 scalpel, 11 non-scalpel, and a combination type of vasectomies. The study follow-up ranged anywhere from 2 weeks to 37 years, and the sample sizes ranged anywhere from 12 to 723 patients. This is a really cool paper, and I would highly recommend each of us, if you have a chance, to just read through this, because it's very interesting and covers several thousand patients. What was interesting is they broke down post-vasectomy pain into initially pain that you just have after the surgery, which we wouldn't label as chronic. They came up with an overall incidence of about 15%, and then also post-vasectomy pain after different types of techniques with scalpel or no scalpel techniques. They did see a difference. This is in just acute and general pain after the procedure, which was anywhere from 24% in the scalpel techniques versus 7% in the no scalpel techniques, respectively. And you can see the confidence intervals there. And then when we talk about chronic pelvic pain syndrome, they found that it occurred in about 5%. What's interesting is when you look at chronic post-vasectomy pain syndrome, they didn't really seem to see a difference between no scalpel or scalpel techniques, which is really, really interesting. The overall incidence of PVPS seemed to be higher than previously reported. And definitely in terms of acute pain in the first few months after a vasectomy, it seemed to be a threefold higher rate using the traditional scalpel technique versus no needle scalpel techniques. However, again, as I mentioned, chronic PVPS seemed to be similar in both techniques. Next slide, please. So what could be the pathophysiology? Now, obviously, the most obvious cause could be some type of obstructive component, right? Because we're doing a vasectomy and there's some type of obstruction. But if obstruction was truly the answer, then why doesn't every single patient that we do a vasectomy on suffer from pain? So I think it goes further than just simple obstruction. There's got to be something different about the patient that creates some patients, having this hyper response to the vasectomy versus the majority of patients that don't really seem to have much of a difference. So there's some studies in the past looking at the neuroanatomy of the cord and the spermatic cord. And there's a few studies that have shown that you can find Wallerian degeneration in peripheral nerves that may lead to chronic pain. So this is in, like, for example, chronic lower extremity, upper arm, lower extremity pain. There's several neurology studies that show that Wallerian degeneration could be one of the causes of this pain, that these nerves are just hyperexcitable. Oka et al. Had done a study then using some really fancy electromicrography studies looking at how the spermatic cord has a real complex innervation of 3 or 4 different nerves, the ilioinguinal, the iliohypogastric, genitofemoral, and inferior hypogastric nerves. So it really is a combination or interplay of these nerves that run through the spermatic cord. Next slide, please. And what we did is, well, how does this apply to our situation? Guys with chronic scrotal content pain or post-vasectomy pain. We did a study, and this is one of the only studies out there actually directly comparing the pathology in patients with pain versus non-pain controls. We took about 57 men who had pain after a vasectomy or hernia surgery, idiopathic pain, and then compared them to healthy controls, patients who were either getting a radical orchiectomy for a tumor but had no pain, or had varicocele that were being fixed and had no pain. And what we did is we did mapped cord biopsies from the spermatic cord throughout the entire cord, and real time did intra-op pathology assessment to see, hey, what's going on in this piece of tissue? Are there nerves here? Is any type of damage occurring to the nerves? Do they look normal? And we did this, comparing the healthy controls to the pain patients. And what we found was really interesting was that in about 84% of the patients with PDPS or CSP, they had Wallerian degeneration in 2 or 3 specific nerve bundles of the spermatic cord, compared to only about 20% in healthy controls. Next slide. So this is the first study that shows that there truly is a difference between patients who have pain structurally compared to healthy normals. And we call this the trifecta nerve complex. There were some of these nerves in the cremasteric muscle fibers around the cord. The highest density was right around the vas deferens, which is really interesting. The sheath around the vas deferens had the highest density of these abnormal nerves. And then there's a small area behind the cord, what we call the posterior cord lipomatous tissue, that also had some of these nerves. Then to see if this truly is reproducible in other patients, we did 3 human cadaver cord dissections just to try to confirm the distribution of the location of some of these nerves. And we kind of mapped it out on the cadavers as well. So this is the first study that actually truly shows a difference structurally between people who have PVPS versus people that don't. Next slide, please. And so this is really the fundamental basis of a lot of our treatment outcomes. Now, how do you assess patients who have pain? It's very difficult to just use the 1 to 10 visual analog score to measure the debility for many of these patients. One of the problems with defining what post-vasectomy pain syndrome is, or chronic pain, is that, is it really pain that's affecting the patient, or is it some other type of effect on their sexual function, on their quality of life? And so Dr. Shosky's al and at Cleveland Clinic have developed this pain questionnaire called a COSI. It's the Chronic Orcalgia Symptom Index. And what it is, it's a validated tool that basically measures not just pain, but effect on sexual function and quality of life. So it really captures how much debility the patient might be having when they're suffering from chronic pain. Next slide, please. This is just what the cozy looks like. And again, I'd be glad to send this out to the group later on. But basically, it's a very simple questionnaire. It's 12 questions. Literally just takes 1 or 2 minutes to fill out. But it measures how the pain affects the patient, with the degree of pain, the sexual symptoms, and the effect on their quality of life. Next slide, please. And so again, this tool was validated and then prospectively tested at a few different institutions. And again, I'd be glad to provide references for further analysis going forward. Next slide, please. So now we come to the meat of the matter, the treatment algorithm. So what we did is we did a review of a few hundred articles, about 2,400 articles, looking for keywords for testicular pain, post-vasectomy pain, or calgia over the last 20 years or so, and kind of try to capture all this data into one table to try to kind of crystallize what are some of the best options to treat patients with chronic calgia, once conservative things haven't worked. Let's go to the next slide, please. And again, I know this might be hard for people to see, but these slides are available and we'll distribute this, and feel free to look up the reference. Basically, what we're talking about here is kind of a management algorithm for patients who present with chronic calgia or PVPS symptoms. So obviously, first, you want to try to use anti-inflammatories, antibiotics, neuromodulation agents like gabapentin, anxiolytics, for patients who have high anxiety levels, physical therapy, acupuncture, all the classic types of pelvic floor therapy, all the classic treatment options for non-surgical treatment options for chronic pain in any organ system. Now, if these approaches fail, then where do we go? So we try to divide the patients into, if they seem to have more congestive type symptoms, meaning that their pain seems to peak after ejaculation, or there's delayed pain for a few hours after ejaculation, then it subsides, and they're usually pain-free the rest of the time. We tend to think that they may be more of an obstructive component. So in those patients, we tend to go more in the direction of vasectomy reversal, because the theory here is that, hey, we're going to put them back the way they were. If there is an obstructive component, hopefully continuing the flow through the system, reducing the pressure in the epididymis might help. And the success rates range anywhere from 69 to 100% in various published studies. If this fails, then we go more into a nerve direction. The other scenario is that you have a patient who presents with PVPS but has unilateral pain. The pain seems to be constant, doesn't really seem to be affected by intercourse or ejaculation, seems more like a nerve type of pain. In those individuals, we'll start out with a targeted block where we actually, we do this in the office under a little bit of IV sedation or nitrous, and basically inject lidocaine, marcaine, and steroids right into the external cord area around the spermatic cord and also within the spermatic cord. And the idea behind this is that if there is a nerve component, these patients should have some temporary resolution in pain. We've done some studies looking at cord blocks, and especially Dr. Levine up in Chicago. He's done a lot of studies looking at the predictive value of cord blocks before any further intervention. And they found that if there's about a 78% positive predictive value, meaning that if they get a temporary response to the cord block, there is a procedure called targeted denervation of the spermatic cord, or microsurgical denervation of the spermatic cord, that we can perform, where they are more likely to have a response or a more permanent reduction in pain. The published outcomes for targeted denervation or microsurgical denervation of the spermatic cord range anywhere from as well 77 to 100%. Again, this is a quick outpatient procedure where we bring up the spermatic cord and then we ligate those 2 or 3 nerve bundles I was telling you about. There isn't any effect on the erections or fertility or anything like that. This is purely targeting the muscles, basically ligating the cremasteric muscle fibers, ligating the vas deferens around the vas deferens, the sheath right around the vas deferens, and then the posterior fat component. Now, A lot of patients also come to me sometimes, wondering about vasectomy reversal and how the effect of vasectomy reversal helps with PVPS. What's really interesting is many patients, if you follow them several years out after vasectomy reversal, they usually occlude. Eventually the anastomosis site usually scars off. But what's truly impressive about guys with post-vasectomy pain syndrome is that usually the pain doesn't come back, even if their sperm count goes down to 0 after we do a vasovasostomy. So that tells you then that there must be something more than just pure obstruction, because in these individuals, their pain doesn't come back, even though the system's now obviously completely obstructed. So we feel that, probably what's happening at the time of the vasectomy reversal is that we are doing a mini denervation or neurolysis because we're cleaning out any clips that might be on any neuromas, anything around the vas ends, and we're also cleaning that perivasal sheath. Because of all the studies we've done, we really see that the highest densities of abnormal nerves resides right around the vas deferens. So that's why I think, that may explain why vasectomy reversal helps, is that not only is it relieving obstruction, but it might be doing a mini denervation. Now, what happens if a denervation doesn't work? There are some other options. We can then do targeted perispinatic cord cryoablation or ileoinguinal cryoablation, where we can go higher up. Many of these patients sometimes have referred pain going up into the groin. The theory is that once these nerves become hyperactivated, even once we take care of the pain lower down or the dysfunction lower down, they may still have some radiating pain going up to the groin area. And we can come up and target that by doing cryoablation up in the ileoinguinal area. If that doesn't work, we can do Botox injections along the cord. That has about a 60-70% success rate. If that doesn't work, we can try peripheral nerve stimulation. There's a new device called StimRouter that we can actually implant along the ileoinguinal nerve. That sometimes helps, kind of like sacral neuromodulation, but this is more peripheral. If that doesn't work, there are new stem cell growth factors that can be injected. There is always a last resort of radical orchiectomy, taking the testicle out completely. Obviously, I'm not a big fan of that, and that's kind of the last resort because a certain percentage of these individuals may develop phantom pain. And so you have to be kind of careful when you go in that direction. If that fails or we develop phantom pain, we can do something called target robotic abdominal denervation, where we go inside the abdomen and ligate the genitofemoral nerve and the iliohypogastric higher up, within the intra-abdominal cavity. And that has about a 70% success rate. If all of these fail or the patient doesn't want to go through with surgical options, then obviously we go back to chronic pain management, neuromodulation techniques. And so this kind of summarizes kind of all the literature that's out there over the last 20 years in terms of different options and things that we can do. Obviously, these surgical options are really more for the chronic patient who's really got debilitating pain. I mean, obviously, we want to hold off on doing surgery unless there's, no better option or the patients really are frustrated. So this is kind of a microanalysis of kind of end stage, really tough cases. So obviously, this is not the first line treatment. However, for many clinicians out there, if you're having individuals who, you've tried some of the conservative things, some initial approaches could be medications and then maybe even doing a series of blocks. I've had some patients where, you can bring them in once a month for three episodes or series where you can actually just inject some lidocaine, marcaine, steroids. And that seems to give patients some prolonged relief and also gives them some hope. So the key thing is really to really provide a supportive role to the patients and really help them through this process in terms of, trying to figure out, what might be going on. Obviously, before we jump into any surgeries, most of these patients have had an ultrasound, some type of upper tract imaging to make sure there's no other cause for referred pain, radiating down to this area. But once that's all been explored, that's when we go into this surgical route. Next slide, please. So in conclusion, chronic PVPS is a challenging condition to treat, but it appears that it's seen in up to 5% of vasectomy patients. What is intriguing is it doesn't seem to vary too much based on the technique that's used. PVS does seem to have a significant impact on the quality of life of patients suffering from this condition. If you look at the studies using the COSI measuring tool, you can see that the debility from this is comparable to living with like chronic Crohn's disease for like 10 years, chronic back pain for 10 years. So when you look at it as a comparison to how much it impacts the patient, that's quite a bit of an impact. And there appears to be some evidence-based data to support a structured treatment approach to patients with PVPS. And so with that, I'll end and then kind of open up for questions because I'm sure there's plenty of points to discuss.
Ahora cena. Mariadna Sikil.
Joe, that was fantastic. We've got a few questions coming in. And can you see the questions there, Sidjo?
Yes. Okay. So maybe I'll
A
start.
large part of post-vasectomy pain syndrome being psychological and giving patients hope. And you spend a lot of time sympathizing with them.
Yep. Yep. So I'll go through some of these questions. So if it were 5%, I'd spend all my time. Okay. So part of the problem is that many of the patients who suffer from these issues never go back to the individual that did the vasectomy. One thing, I'm kind of keeping a track or a survey of some of the patients that I'm seeing right now with PVPS, and it's close to about 90% of them do not want to go back to the physician that did the vasectomy. And there is a feeling of resentment. And part of the problem is that because if we sit there saying, listen, this is impossible, it never happens, they're unlikely to come back or even mention too much. But it doesn't mean that these patients they may go away from the surgeon that did the vasectomy, but it doesn't mean that there isn't an issue or a problem. So, and that's why this study, I would invite everyone to kind of really look at this meta-analysis. It's really interesting and very intriguing, and really is kind of a neutral assessment because it's a group of non-surgeons who are just kind of statisticians looking at data, which is sometimes not a bad way to look at it because it's not too close to the source. Because if you ask most surgeons, I mean, none of us ever have any complications, it doesn't happen. But the reality is that there probably is, some degree of dysfunction at a certain level. Now, what I do want to emphasize is that I don't think this has much to do with the surgical technique or anything that was done wrong or anything during the procedure. I think, unfortunately, what we're seeing is that it probably has more to do with the patient. And as time goes on, I'm sure in the future, we'll come up ways of maybe identifying individuals who are more prone to developing this Wallerian degeneration. There may be a group of guys out there that have this, and then there's some type of traumatic event, because we see similar distributions, not just after a vasectomy, but after hernia repair, abdominal surgery, donor nephrectomy, whatever the case may be. Just to give you an idea about, I specialize just in taking care of PVPS and chronic scrotal content patients. About 60% of my patients come from outside Florida and 20% are international. And unfortunately, I have patients from many of some of the individuals who are on this exchange board and stuff. So it is interesting because on the boards, everyone says, hey, I've never had an issue. I don't deal with this. I don't see many of these patients, but unfortunately, I am taking care of many patients from many of the top guys who do vasectomies on this board. So there is a disconnect between what we publish and say and some of the dysfunction. Now, is there a psychosocial component to this? Absolutely. I mean, and it's well studied and documented that their coping mechanisms may be off. Certain people respond to pain stimuli in different ways. So absolutely. I mean, there may be certain individuals who are just not designed well to deal with a little bit of pain, and then it becomes a bigger problem. However, it doesn't mean that it's not a problem. And so I think it's always important to make sure that we don't discredit these patients at the same time completely by saying, hey, it's all in your head, you're crazy, because I don't think they are. There may be a sensory perception problem. And if there's a way we can help these individuals to get out of that cycle, I think it's worth a shot.
Hey, Joe, thank you. You had mentioned in one of your first slides, the definition is refractory to conservative treatment options. Now, if I have a patient, and I've had a couple of patients who respond well to either amitriptyline or testosterone therapy or your suggestion of oxytocin tadalafil combination, does that mean that they don't have post-vasectomy pain syndrome because they weren't refractory to conservative options?
You're right. I don't know the answers to that because and that's why we use the cozy as well, because it's more how much it's affecting their quality of life. So for example, if an individual is technically pain-free, right, but has to live with 3 or 4 medications and doesn't want to live like that, that impacts their quality of life. So that's why the cozy kind of captures individuals that may not have a lot of pain, but just don't like the way things are going and want an alternative. And so
las cosas si quieren una alternativa. Por eso es que quiero que la escala de 1 a 10 no captura lo que ocurre, porque muchos pacientes dicen, si tomo gabapentin tengo 0, pero no quiero tomar gabapentin 3 veces al día porque me hace sentir mal.
well, where does that patient fall? With most vasectomy surgeons, he's going to fall as a no problem patient because this guy has no problems. He's got a little pain, but if he takes gabapentin, it's gone. So he doesn't have PVPS. But for this guy, he's going to call me saying, listen, I'm tired of living with this. I don't like the side effects of gabapentin. And this is really debilitating me. So that's, I think, where the disconnect is that there's a big gray zone of what truly is dysfunction. And I don't think any of us really understand that. I have one guy that was a professional cyclist. And so basically had pain that affected his ability to do like 100-mile marathons, but he could do 20 or 30-mile marathons without a problem. So most people would look at this and say, listen, if you can ride 20 or 30 miles competitively, you're pretty okay. I mean, that's not an issue, but for him, his livelihood was 100-mile races. That's what his livelihood is. That's what he wants to do the rest of his life. And he's like, I can't live like this. This is the bane of my existence. So what do you do in that situation? So, we did a denervation on him and he loves it. He's competing again. So for this individual, where would you label him? Because I'm sure according to the vasectomy surgeon, this would be a non-issue, this is a crazy guy, right? I mean, but for this individual is a highly functional individual, normal, logical, from all other aspects is a very successful individual and stuff. So is it wrong for him to want to be able to function the way he was before the vasectomy? And that's a tough question, right? I mean, so that's where there's a bit of a gray zone in terms of, is it truly dysfunction or is this just part and parcel of any procedure? And I think what I want to clarify is I think this is more part and parcel of what could happen with any procedure. I don't think this is specific just to vasectomy. We see this across the board. I take care of guys who come with chronic pain after a cardiac cath, just in the groin for a cardiac cath. I mean, so these are patients that needed a cardiac cath for a life-threatening event, right? I mean, because they needed that cath to get the stent in their heart. Otherwise, they wouldn't be here. But what they're left with afterwards is chronic groin pain. So again, I don't think this has much to do with the technique, but I think there are some individuals out there that have this propensity. And right now, we just don't have the tools to identify who these people are ahead of time. And we've looked at a lot of data in terms of, are they specific predictors, their personality types, things like that. It doesn't really correlate that way because sometimes after the hyperactivation, that's when their anxiety and everything pops up, and they never had an issue to revolve around. And after this, it just becomes really debilitating to them. So it's very difficult to identify who these individuals are. But I do think that just like in the world of chronic pain, there's certain genetic indicators right now that people are identifying certain people that respond to certain medications better than others. I think there's a group of individuals out there that we know might be a problem, but we don't have those genetic tests available yet, but I think it's coming,
Thank you, Sergio. We have a fair number of questions still, but we want to stay on track. And I'm being reminded that it's 10:38 and probably time to move on. Even I have 2 or 3 questions, and I'm sure that some of our audience will be frustrated. I mean, here we have the ultimate resource. So people really want to tap you for information, but I want to stay on track. And so I'm going to hand this back to Michelle, and who is going to introduce our next speaker. And then maybe we have the option to come back. That will be up to Jonathan. So Michelle, if you can take over.
Yeah, thank you, Doc. What I would suggest is if we can make a copy of all the questions, Doc, put them on a worksheet, and then we can put them on the network, on the vasectomy network. And if you have time, Sergio, you could probably react to all of those questions, and then the discussion will go on, because this is the aim of the session. It's an update, so we want to go and make a good job at responding to all the questions. So if someone can, of our group from World Vasectomy Day, can make a copy of all the questions, and we will share them. We'll do the same for all the
I'd be
people.
glad to. Yeah. Yep.
Okay,
And then I can answer them
thank
all
you
and
so
post
much.
them, and then we can discuss it later.
Even
Thank you. Thank you, guys.
I
Thank
have
you
another
very
thought,
much.
Michelle. Can you hear me? It's Jonathan.
Mhm.
Another possibility is also that we put all those questions together and we set up a little time with you, Cijo, so we can record a conversation and we just finish all the conversation. Then we'll put that recording online as well. So you don't have to spend all the time writing
Perfect.
the answer, make it a little
Perfect.
easier.
Okay, that's another option.
Okay.
Yeah, thank you. So we're
Okay.
Well, thank you very much.
And I put my email that, yeah, no
Really
problem.
good.
thank
And I
you
put my
very much.
email, I put my email in the chat as well. So you guys can always email me directly if you have, patient specific questions and stuff. So.
Thank you very much again. Okay, so our next speaker then is
Thank you. Thanks, guys.
Dr. D'Amica Pereira. Dr. Pereira is, and we're very honored to have him because he's the Global Medical Director at MSI Reproductive Choice, which is one of the world's largest provider of effective and safe contraceptive services in the world. So Dr. Pereira holds a medical degree from the University of Colombo, a master's degree from the University of Manchester, and a PhD from Walden University in Minnesota. So we've been all over the world, as we can see. So we're very happy to benefit from his large experience in public health and international health service management. So Dr. Pereira.
Thank you very much, Michelle.
Okay,
let me
very
load
good.
up my slides. Well, guys, it's an honor to speak here and welcome again, everybody. And thanks, a very big thanks to World Vasectomy Day for giving me the opportunity to speak in front of you. Could I have the control to load to share my screen, please? Matt, was it?
Now you have the control of your own screen,
thank you.
Dr. Pereira.
Thank you. Here we go. I hope you can see my slides.
Yes, very well.
Brilliant. Okay, so we are going to take a step back from Cijo's brilliant technical conversation, which was very, very enlightening, Cijo. Thanks a lot for that. And we're going to spend the next few minutes looking at where vasectomy is in the world today and what we could do to improve the popularity, visibility, and uptake of vasectomy globally. And to look at a few ways in which we can do that. And specifically, I'm going to look at how we could make it cheaper, simpler, and more standardized. And then we're going to look at how those things would factor in to make vasectomy more popular. Before I proceed, no conflicts of interest. I did want to say that I'm using a few excerpts from images from MSI vasectomy guidelines in my slides, but I'm using them purely as examples. I'm not trying to get any of you to follow MSI guidelines or anything like that, just to get that out of the way. Three objectives from the session today. Sharing our experience as to how vasectomy could be provided in a cheap manner, and then to look at what a standardized vasectomy guideline could look like, and then spend a few minutes looking at the pros and cons of standardizing vasectomy and in fact standardizing any surgical procedure. To start out, compared to female sterilization, vasectomy or male sterilization remains quite less popular. And that's truly, truly sad, because as you all know, it's safer, it's faster, and it's cheaper. But because of multiple reasons, it remains quite less popular compared to tubal ligations, and that gap is expanding. And this is the last 40 years, and you see the gap between the two is expanding, and we're trying to bring it back to a better place. Now, in our experience, MSI, we currently work in 35 countries and we provide about 30,000 vasectomies a year. And it might sound like a lot, but I have to say that's compared to 400,000 female sterilizations a year. So we ourselves are struggling with some of these things, and these are coming from our experiences. So what could make vasectomy popular? Some ideas. One, we definitely need governments to understand it better, to be familiar and comfortable with it much more, and to integrate it in government family planning programming much more than it is currently. And some of you would know that there were countries who did this in the past, and in those countries, even after the government stopped giving that prominence to vasectomy, the procedure did not drop in popularity for a long time. And still we see today the bigger vasectomy numbers in the world are sometimes seen in countries which used to have national programs. Secondly, we need similar interest from big donors, because unfortunately, most of the low-income countries in the world and a fair chunk of the low middle-income countries in the world, their family planning programming and to a degree their family planning agendas are supported and driven by donors. So we need the USAIDs, the JICAs, the UK FCDOs, the Canadian, European, Australian governments to be much more familiar and comfortable with vasectomy and to promote it. Then moving, turning towards ourselves as clinicians, I think we need a better, a uniform, simpler, positive understanding of vasectomy. And I'm not talking about vasectomy providers per se, but the bigger clinical realm of clinicians, nurses, midwives, doctors. Everybody needs to have a clear, simple, positive image of vasectomy that they can communicate to people easier and better. Then when it comes to organizations or facilities or hospitals that provide vasectomy, we've seen that we need what we call whole site training approaches. What I mean by this is, while it's a urology team or a doctor who's specially trained who provides vasectomy in any of these places, everybody from the person doing the patient registration to the receptionist to the team that does the antenatal care clinic and the nurses who run the vaccination counters, all of them have to be equally comfortable, familiar with the simple view of vasectomy so that they can promote it across the hospital. And then we definitely need mobile services. And this can take one of many forms. It can be 2 people on a motorcycle, it can be a small team on public transport, or a team providing vasectomy in the back of a modified van. But we need people to have vasectomy services closer to where they live. And as you know, from Amazon Prime to eBay, people need convenience. And across the world, we see people asking for that. Then we need what we call cascade training, because unfortunately, like one vasectomy champion giving his or her knowledge and skills to a few more, and spreading it that way, it's not fast enough and it's hard to scale. And I'll show you what that could look like. And lastly, task shifting, meaning we need to make vasectomy a simpler procedure that governments and health regulators are comfortable with, to say, this is a OPD surgical procedure. You come in, quick counseling session, quick procedure, and then you're good to go back, and we will provide you follow-up following that. So I think these are some of the things that we would need. Now, the first thing, how can we make it more affordable? And at MSI, we've done this by using a few tricks. First of all, we've turned it into a model that can be provided by a 2-person team. Right? The practitioner himself or herself, and then an assistant who also looks at pain management and keeping the client engaged throughout the procedure. We've introduced what we call pre-packed vasectomy kits, which are surgical kits that we centrally purchase, bulk order, so that we get the volume benefits of pricing. And these come in their own packs. I'll show you a picture later, and they're ready to go. They are reusable, re-sterilizable, and teams can sterilize and pack these bags, pack these into their bags before the next day's service provision. And we've created lists of consumables saying this is the list of things you need for one client for one vasectomy, so that teams can have them ready at hand, and maybe the day before if there's a big vasectomy drive the next day. Similarly, the few medicines you need, the antibiotics, the pain medication, prepared lists so that they can be in a small Ziploc bag ready to go, that you can write and dispense on the day. And then the concept of vasectomy days. We've done a few with World Vasectomy Day as well, where we do demand generation and we gather men who want to get the service to a site where a few mobile teams would be working on the day. And finally, we've introduced what we call group information sessions, which is sort of taking the first bit of counseling, the more general information about vasectomy that we can give to a group instead of having every bit in as a one-to-one counseling session. And we use this so that if on a vasectomy day, let's say we have a couple of hundred people gathered, because there are people who come in for the service, and then there are other people who either accompany them or who are there just because they're curious. And this initial information sharing can be given to this larger group so that everybody is informed and made aware of vasectomy and how easy it can be. And through a combination of these things, we've managed to bring vasectomy to what I call a 30-minute, $30 procedure. That is the standard that we operate at in MSI. And I have to remind you, like, we provide vasectomies from Papua New Guinea to Sierra Leone. So these costings are what makes it possible in most of these places. We have our own vasectomy guidelines. Actually, we have one of these guidelines for every service we provide. And that is it's a 50-60 page document, but inside it, there's like something like this, just for you to have a rough idea. You don't need to read the details. There are like 13-14 pages that outline the procedure, how we expect our providers to provide the service. These are just examples for you to have an idea of what it looks like. And then we also standardized the other things surrounding the vasectomy itself. We have pain management guidelines, infection prevention guidelines, counseling and consent. These cover all the services we provide, but each of these would have specific language on how to do this for vasectomy and how to do this for vasectomy. And those are cascaded through our provider networks. And these guidelines are revised 3 to 5 years, and each revision is informed by the clinical best practice and evidence that comes out in that period, so that we gather those pieces of information and decide which ones would inform the next revision of the guideline. This is what a vasectomy kit looks like at MSI. So these, as I mentioned, we order them as it is in this particular pack, these items, and this is what the medications and consumable lists look like. Again, I'm not saying you have to do this, but it's just an example of how it could be done, so that across the world, when we say get a vasectomy day ready in Papua New Guinea tomorrow, they know how to pack for it. And lastly, instrument processing, like, how to process the instruments after, because most of these, the kits are reusable. So how to wash them, how to repack them, re-sterilize them, and what to do with your gloves and instruments and everything. And then we have set incident management systems which are standardized, meaning There are all possible incident types are categorized into red, amber, green, and everybody knows like a red vasectomy incident is X, Y, or Z. And A, B, C would be amber, and there are specific ways of reporting those incident types and specific ways of reviewing incident types, extracting the learnings from each incident and disseminating the learnings across the network of providers. Then we also have systems for tracking referrals when we refer somebody because of a complication, getting feedback from clients and following clients up. Then protecting the providers and the institutions and the organization itself, standardized consent forms. This is what a consent form, this is the language it should have. This is what a vasectomy clinical record should look like, so that we can conduct record audits when we do clinical audits, and so that when we ask for a patient's record, when there's a adverse event, we know exactly what we are going to get and what to expect. And then client handling and systems to check if the standards are being adhered to, which includes the incident management system, but also includes multiple levels of clinical audits and data streams and reporting systems that every country has to abide by. And this is what the training cascade looks like. The aim of this is to make trainings possible at different levels of the cascade without the top being always involved. Right? So we have the central clinical team that I lead. Then we maintain a network of lead trainers or master trainers who carry out TOTs to train trainers. That creates the facility trainers or the clinical trainers who then can go and train doctors to provide vasectomy services. And the beauty of it is if a specific country says, I want to create 20 more vasectomy providers, they can reach out to a clinical trainer without involving us all the way at the top, and those trainings can continue. Last slide, as I mentioned, there's a lot of upsides to standardizing vasectomy this way, right? Learning from incidents, setting up standardized audits, the training cascade, bulk purchasing of drugs and equipment, making sure that for any organization, the guideline and the trainings are in sync with the operational realities they face day to day, time, cost savings, and all these things. And then there's a few downsides. It can stifle innovation, right? And then it can be a sort of a turn off to the more technical potential recruits. And then you risk your reputation in a way that you don't by running it one at a time in a way, because if a vasectomy client has a bad experience in one corner of the country, that tends to affect the full organization because it's known as a MSI vasectomy. And I think that's it. Yeah, questions?
Thank you very much, Dr. Pereira. That was very, very interesting, very relevant to all the world situation. And maybe I would like to ask, I don't know if Dr. Kaza is still, or Dr. Baljit are still online, because I know they've been doing a tremendous work. Yeah, Dr. Baljit seems to be there. Can we give her the words, or she can ask you a question related to the great movement they built in India for no scalpel vasectomy? That would be very interesting to have their input on what you just said. Dr. Baljit or Dr. Kaza?
Yeah. Thank you, Michelle. It's I'm so excited, so happy to see you all. And it's such a wonderful thing. Thanks to Jonathan Stack for putting us all together, because it's been ages we connected. And it was very enlightening to listen about the similar experience and the same cascade effect that he has put up. And I do not know what is your specific question, but I think broadly the framework and the structure would remain the same. Same if you wish to build a program. And I personally feel so proud of being part of Dr. Kaza's team and the way he built up the program. There is so much of detail about it because it's taken decades to build it in India, and we still are strong enough to carry it on forward. We have national standards in position. We have all the consent forms and the case record sheets and the post-operative instruction sheets and the QA document and everything in position. But definitely the numbers are falling. We have some technical issues about the transmission of the DBT and some more issues, which I think we leave it for the day. And wonderful, wonderful. Anything specific you wish to ask? I'm too happy to answer.
Thank you very much, Baljit, for your testimonial. Maybe Doug, could you ask a question about, not a question, but a comment about your experience in different countries, and I've been participating to NSVI, No Scalpel Vasectomy International. I see some similitude to what Danica just proposed as standard. Doug,
Yeah.
still...
Yeah, I think that the top tiers of what Danica proposed is really what has been done most effectively by World Vasectomy Day through Jonathan, especially when it comes to influencing governments and donors. We're a couple of steps down because we provide some guidance for the in-country vasectomy providers and try to get them using standard packs. So we're kind of the boots on the ground. And in terms of influencing patients, Jonathan would, and World Vasectomy Day would be a little bit higher in terms of trying to get governments to reimburse their providers or have spirited vasectomy provider programs within the countries. When that doesn't happen, then No Scalpel Vasectomy International tries to support them financially, because as I always say, everybody's got to pay the rent. So if you have spirited and skilled providers in a particular country, but they have no way of getting paid, then that's where NSVI steps in. So I look upon NSVI as service provision through missions, but also support of in-country teams to provide services with financial and material support from NSVI.
Thank you, Doug. That's very
Michelle, can I come in a bit?
Yeah.
Dr. Kaza here,
Oh,
Michelle.
Dr.
Can I have a word?
Yeah. Of course.
Nice meeting you. Very nice seeing you. It's a long time. It's a long time indeed. And it's nice seeing you once again. It was a beautiful lecture, Dr. Pereira. And in fact, many of these things, of course, you had a wonderful picture of cascade training, etc. We tried this in India. About 4,000 surgeons, we built 8,000 surgeons. And many of the techniques that you have mentioned, of course, I think you had concentrated quite a bit on the costs. But the things that you have actually mentioned, we have adopted here. We've tried all these. The cost angle in India, of course, since most of them are done in government systems, so naturally that has really not been quantified. Now I work private sector and I suddenly realized that I don't think when we say that vasectomy is free, it's really not free because there's a lot of doctors' time involved and there is instrumentation, there's the drugs and so on and so forth. So I think there are a lot of things of that kind which have to be actually put into the cost. So I think maybe if you look that way, but I think $35 is a bit too steep for this country. I don't know. I would like a comment from you whether in you have different experiences as far as the cost angle is concerned. Maybe you don't as much in some. I'd like a comment from you.
Yeah, of course, Dr. Kaza. So the 25 to 35 reference range is a generalization, and that includes physicians or clinicians'
yeah.
time in it. And where we have sort of higher end doctors providing the service, that tends to be the bigger part of the cost. And I think for a country, for let's say a private clinic like yours, the trick is to first cost the procedure, and that should include every little thing, including the electricity bill, the water bill, every little thing that factors in. And then once you have the breakdown cost, you can look at that and figure out which of these can I cut. And you will usually find 2-3 in a 10 to 15 itemized costing breakdown that you can cut. I don't know if that helps.
That's interesting. That's interesting. Actually, this wisdom dawned on me after I left the government service and came into private practice. I think there are, in fact, a lot of inputs which go into providing a service that is not counted when you do it in a government service. It's been an excellent talk, Dr. Pereira. Excellent talk.
Thank you very much. It's my honor.
I'll just, we're going to have to move on. I'll just have a last question to Dr. Pereira. How do you, in your network, how do you make sure that the health professionals are complying to your standards? I mean, when you do guidelines in a country like the AUA guidelines or the UK guidelines, I mean, they don't have any means to see if people are applying the guidelines. But in your network, I mean, they're your sort of employees. They should conform to what you're saying. How do you monitor?
That's a brilliant question, Michelle. So just to clarify, we have our own providers who are our staff, but then we also have private providers that we train and supervise. And then we also sometimes provide trainings to government staff where we have government agreements and contracts and so forth. So going back to the question, so how do you make sure that people are doing it according to our standards? There are three tricks to it, let's say. One is finding out if they are adhering or not, which we do by using a tiered clinical audit system. So for example, every country program of MSI has a clinical team, and they have to go and do a clinical audit of every service location once a year. That is something like the CQC audit system of the UK, right? And they will go and check, and they use a standard checklist to make sure. And on the day, and now we are doing those, we are starting to do those remotely. So that we can increase randomness, so that we don't have to inform that we are coming a few days before, and we can just call up and say, turn the camera on, we need to watch, right? And so that's one thing. And then every clinic and every country program and every country director is scored according to those findings. And the second thing is the incident management system. When something goes wrong, when we ask for, because we have, as I mentioned, standardized clinical record forms and consent forms, we get those documents from every incident and we check, have you skipped things? Are there boxes left unchecked? Are there boxes left empty? Right? Are all the drugs mentioned clearly and things like that? And when we see mishaps, we have that conversation with that team and also the clinical director of that team. And finally, and I can't stress this enough, accountability. You need to have accountability. It's like we maintain a careful balance between what we call a no blame culture when it comes to reporting mistakes and learning from mistakes. But where we see trends, either we have a very bad clinical audit where we visit 5 clinics and they're all not up to par, right? Or where we see a particular type of adverse event happening repeatedly and it is not being addressed, then we have accountability. Then we will escalate it to the clinical director of that country, to the country director. And if they don't act, we'll escalate it to the regional director or all the way to the board and say, such and such a country is not doing that particular thing right. And we've pointed it out to them for 6 months now and they're not fixing it. And then the heavy guns will step in, and nobody wants that. So that last bit is there as a last resort. We really try not to pull that out, but everybody knowing that it is there helps a lot.
Thank you very much. So you're well aware of these issues.
Absolutely. You know, unfortunately, we can't depend on people to do the right thing simply because it's the right thing.
Thank you very much, so much, Damika. That was so precious. All your information are
Absolutely. I hope it was helpful. And Jonathan, if you can send me the other questions, I see a lot. I will try and answer them either on a document or in person. Thank you very much.
This is exactly what I was going to say. We're going to take all those questions, put them on the network, and have them share to all the participants. Thank you very much. So we will give you in the chat room, we're going to give you the link to the evaluation form. Please do complete the evaluation form. You add it in your message also. I don't see it right there, but Matt or Deidre, could you please, or Jonathan, here we are. We have the, look on your right in your chat box, you have the evaluation form. Anyway, we will send the evaluation form, the link to the evaluation form to everybody who participated, to all of them. So I'll pass. I think we have Deidre. You have some messages to share to us with us.
Yes, I do. What I would like to do right now is just take a few minutes of your time to introduce you to a concept that we've been developing for a while now, which is to create a global vasectomy doctors directory. We want all of you to participate. We're not quite ready for prime time yet. We're in a beta test, but I am going to share my screen and show you approximately what we are looking at for the way that this directory is going to work. Just a second. Okay, it should come up now. Okay, so this is the way, this is our new website, and this website is not quite ready. So that's another reason that we're not listings an enormous aid to men around the world, because we want them to be able to find a provider wherever they live, or the nearest provider to where they live. We don't care. We're going to try to list everybody. We have free listings. This year, everything's going to be free, but I wanted to show you sort of how it's going to work. This map will be interactive, and I've put in a few listings, and pardon me for not listing more people, but we had a little difficulty with longitude, latitude on our API with Google Maps. If that means anything to any of you, please get in touch. But at any rate, we had some difficulties yesterday. But we have these sample listings right now. And I think I'll just go in. It tells you who's closed. It tells you when people are open, and it'll have a rating system so that each of you will be able to add your ratings or gain your ratings here and put any kind of information that you want in here. I'm going to go ahead and pick Sarah Miller for this moment to show you an actual listing, I hope. So when you click on her, you know, if you find her, you say, oh, this looks like somebody I'd like to, you read a little bit about her. It'll have a snippet of information about her. You find out what kind of a doctor she is, what her clinic name is, the address, the phone number, how to get in touch or get in touch by email. She can put in her Facebook listings. She can upload her photo. And then we have her hours of operation and what she specializes in. She specializes in no needle, no scalpel vasectomy. So we put all of those. We have reversals, we have languages spoken. She can put in her website. Over here, she can put in an about statement. discussing, you know, more about her to attract the people that are trying to make a decision about who to have do their vasectomy. Here you see that she's going to be located on a map, and you can drill down and get directions if you want. And then there'll be a place where she gets her reviews. We want to make this for everybody right now. Not everybody needs this level of listing. So what we've also done is we've put the listings in kind of a tier, because we do want to charge for the people that want really enhanced listings, because World Vasectomy Day is a nonprofit. We very much need support in order to even keep these websites going and to develop these ideas. We need money. So we thought what an easy way it would be for people that want listings, that are looking for business, we can help. And so we will have tiers of listings. The first tier is going to be just free. It's your name, city, state, province, a map spot, ratings, you know, your country, obviously, and your phone number. But if you want more than that, we will give you, you know, these provider sections, the hours, the languages you speak, your specialties, your photo, your web link. And then if you really want some more help from us building your business, we have a final link tier that will include Google Ads. We have a Google ad program that we can direct towards your practice. So that's our next and final, the highest tier. These are not going to be expensive. The longer listing, the medium listing is going to cost maybe $30 a month, up to $100 a month if you want more help from us. So we're hoping that this is going to be ready in the next month, and that we will be able to integrate all of your listing data. And to that end, what we've also done is we've created, which you are going to receive, this WVD provider directory. And this is all the detail that we are going to ask you. You know, the letters that go behind your degree, which I don't understand, but I know that other people do and want to put them there. The type of doctor you are, your clinic name, your address, your you know, your suite number, your floor, your country, your region is state, province, etc. Your city, your zip, office phone, office email, Facebook, Twitter. You can put it all right here. Everything except your photograph. We really can't, and those kinds of links we're not going to handle here. But once we create this listing for you from this data, we'll automatically create your listing, and then you can go back in and upload your photos, testimonials, videos, anything that you want. All free until December 31st, and then you will have to a tier level, either free, $30 a month, or $100 a month. Pretty simple. We are looking for feedback. We are not done with this yet, and if anybody has anything they want to add during this development process, we love to hear from you. And you can put in the forms of payment, the insurance that you accept, and then just a date that you turned in the form. Thank you so much. That's basically what I wanted to say for now. I am super happy to see you all here, and look forward to hearing your comments. Thanks a lot.
Thank you very much, Deidre. Probably, Jonathan, you would like to give us a little update on what is coming this year with the World Vasectomy Day.
Yes. Hi, everybody. Can you see me? Because Deidre, you're sharing your screen. You got to stop sharing.
Let me get it off.
Okay. So first of all, what an amazing group of people all of you are. Just to have this event and just to see everybody from so many parts of the world is really, especially thanks to Doug, Michelle for, you know, being such amazing collaborators on this project, and Sijo and Damika for taking the first stab. One really quick note is we are having those other lectures during the year. We'll be sending out information. If anybody wants to speak at, please let us know. You know, submit to Doug and Michelle and Escar Guarin your you know, whatever topic you want to cover, and we really want to make it as inclusive and diverse as possible. And this is something, the beginning of a big ideas that we're trying to play around with. 2020 was a hard year for everybody. We've lost a lot of lives. A lot of people's lives have been severely interrupted. But in many ways, because of the doctors and the institutions and ministries of health around the world, World Vasectomy Day had a fantastic year. I mean, there was more activities, more action, more energy. While a lot of organizations either postponed or canceled their events, somehow World Vasectomy Day actually managed to be larger than ever. So it speaks really to a lot of people. Now, in some places, numbers of vasectomies went down, but in other places actually went up. And in overall, just the level of conversations and interest has grown, and we're just starting really. I mean, we've been experimenting now for 8 years, but we keep growing. And one of our areas that we're going to grow in is this sort of doctor training component, which is part of the lecture series that Michel was able to organize through his university, Laval University. But it's also part of an academy that we're going to be launching in the coming year, which is to really systematize the work we're doing. So there'll be more activities. Just this month, Deidre and the team of people organized an International Women's Day event, and a lot of people showed up for that. We're expecting to have a possibility of a Mother's Day event and a Father's Day event. We're really pushing hard, like Dominica said, really working. We've already met with the people from MSI to plan out this year. I think this year is going to be larger than ever, and there's going to be just more and more activities. The more you guys participate, just the better it grows. That's really what it comes down to. And I get a lot of credit, and some of the ideas crazy and some not so crazy ones are mine. But the team behind World Vasectomy Day is not that large, but it's incredibly energized and active, and all the people who you don't see all the time, like Katy Cordova or Lucia Torres, now Yia Guarin, and of course Deidre. That's our team. I mean, that's it. There is no hidden groups of people. We just work really passionately, not just because we want to support the work you do as vasectomy providers, but also because we believe that this kind of caring for conscious men is something very important for the planet. It's something we really believe in. And there's going to be more ways of integrating our work and spreading it. But again, it all comes down to you, which is why the directory is so important, why the academy is so important, and why this lecture was so important. So that's really what I wanted to say. We just keep staying in touch. Everybody, we're always open. Anybody reach out. We try to get back to you really quickly. Sometimes we fall short, but we're always pushing and diversifying, coming up with new ways, new media. Any media you guys think that would be useful to have, like any ideas, films or videos, that's what I love to do. So please keep us informed about it. We'll do a better job of sharing it. The website is going to be awesome. It's going to make it a lot clearer. There's going to be an interactive media library so you guys can find all the videos, all of the things that Doug keeps reminding me, where's this and why is that? And I would appreciate that, Doug, because we want to make sure that it's as good as the work you guys do. So thank you all for showing up.
Jonathan, I know you probably were not going to say anything about this, and Deidre probably touched upon that. But seeing that people are leaving, I can't let the opportunity slip away and remind people of what World Vasectomy is doing. I know you just talked about how much more you have been able to accomplish with World Vasectomy Day during the pandemic, in spite of the pandemic. And after seeing what Deidre was talking about with the directory, I can't let the opportunity go away and not remind people that World Vasectomy Day needs support, and World Vasectomy needs support to continue to morph into this organization that is going to continue to do all these things that you guys were talking about. World Vasectomy Day started as a movement, and this is something that Jonathan has said several times in the past, but is more than that. And we need the support as an organization. World Vasectomy Day needs it. So I personally, as a clinician, want to encourage those of you who participated today to look into making some form of donation to World Vasectomy Day. You can go to the website and find a link on how to do that, a donation. Pitch in with whatever you want to help or you want to support World Vasectomy Day, so that we can continue to to have this, activities of the storytelling activities that Jonathan does and the team does, and these activities of increasing the awareness of vasectomy in different countries, in all the different countries that the movement, the organization has been able to be. I'm sorry I interrupted you, Jonathan, but I think it's important that we take advantage of the opportunity so that people understand that these things don't happen out of thin air. These things happen because there's some support, some financial support, and we hope those of you who appreciate what World Vasectomy Day has done pitch in one way or in another and help as well. All right. Sorry about that, but I couldn't let it go. I had to do it.
Thanks.
Thank you, Edgar.
I got out my credit card and checkbook right now.
Well, look, first of all, Edgar, thank you for that beautiful thing. And I know some doctors in the world have access to more resources and some less. Any way you can support is great, but really, we're really working on figuring out other ways of also bringing in resources, but you guys are awesome for that. And thank you all. I don't know, Michelle and Doug, if you have final thoughts or ideas.
Just thank you to our speakers today. It was a fantastic session. As we said, we're going to put all the questions online so you can have access to it. If you have colleagues who were not available today, who wants to look at the session, they can, or manage to get them some credits and their certificate. We're going to meet, your scientific committee will meet in the next few weeks to decide on the next topic for June 12th. We have a big list, so don't worry. We're going to find something interesting and interesting speakers also. And that's it. Please complete the evaluation form, and we'll see you next time.
Thank you. Thank you all.
Thank you. I think we're getting updates. I think everybody here is on the Vasectomy Network Google group.
More or
If
less,
you're
yeah.
not, please notify Michelle or me. Some of you may have learned about this through Jonathan's MailChimp or some other means, but the Google group is really a way to stay apprised of not only some of the technical and social aspects of vasectomy, but updates on more information about those subjects. So it's a good way to keep in touch with the main group.
Thank you very much, everybody. So either have a good day, have a good night, or keep sleeping, and we'll see you all.
Thanks,
Bye.
everybody. Bye-bye.
Bye, everyone. Love from India. Hi, Caesar.